Hi everyone, so I'm going to talk to you today about how women experiencing homelessness in Northern Ireland access and use healthcare, hearing from the voices of service users and service providers. So I recently completed a PhD on this topic at Queen's University Belfast, and I was supervised by Professors Nigel Hart and Dermot O'Donovan. I partnered with Simon Community Northern Ireland for this research. They are one of the largest providers of hostel beds for people experiencing homelessness in Northern Ireland, and they were involved throughout the research design, and they also provided opportunities for recruitment as well. I'd like to say at this stage, I'm sorry I can't be there live with you today, but please feel free to send any questions or comments or just thoughts my way about this work. I'll give you my email address at the end. So before I start talking about my work, I just wanted to highlight some background. People experiencing homelessness have poorer health than the general population. I've picked out some stats here from across the UK and Ireland. Their life expectancy is 20 to 30 years less. On average, they have 7.2 long-term conditions, which is more than any age group in the housed populations. Self-harm rates are 30 times higher, and in Northern Ireland, in a recent survey, 68% of people who were living in homeless hostels had a diagnosed mental health disorder, and that's compared to 20% of the general population. Then looking at access, so Gillian Tudor Hart described the inverse care law in the 1970s, and he said the availability of good medical care tends to vary inversely with the need for it in the population served, basically meaning people with poor health are more likely to struggle with accessing healthcare. So that's what led me to focus on access as well. So today I'll talk a little about a scoping review that I carried out last year that acted as a bit of a springboard for the next steps of my work. I'll then describe my data collection, some brief findings and the implications of that work. So my scoping review was published last year. You could scan that QR code at the top right if you're interested in reading the full article. I included 56 articles in my review that considered access to healthcare for people experiencing homelessness across the UK and Ireland. My findings were categorised by these 6 themes. As you can see, the themes are staff education, flexibility of systems, service coordination, patient preparedness, complex health needs, and then my video hides that last one there, but holistic patient-centred care. The first 3 themes there are examples of facilitators that could improve access, and then patient preparedness and complex health needs are maybe more about highlighting the characteristics of the population that maybe make health and health access slightly more complicated. And then finally, holistic patient-centred care highlights the need to consider homelessness and people experiencing homelessness more holistically rather than just addressing individual health needs in silo. So the limitations from the review are indicated here, and those limitations were the lack of voices from women experiencing homelessness. There was a lack of research outside of urban centres. A lot of the work was done in London and Dublin. And finally, there was a lack of input from further stakeholders such as healthcare providers. So I decided to design my research question to address these gaps in the literature. I decided I would include women's voices, conduct research in a part of the UK that hadn't been represented, and include other stakeholders such as healthcare providers. So that led me to my research question, which was, what is the nature of access to healthcare for women experiencing homelessness in Northern Ireland, and how can it be improved? So data collection took place between January 2022 and May 2023, and I chose to use interviews and workshops to answer this question. So I interviewed 10 women experiencing homelessness, 6 hostel staff and 3 healthcare staff, and that was done towards the start of 2022. I then hosted 2 workshops, the first one in Queen's, which had 13 participants that were people involved in developing and undertaking policy and healthcare educators. The second workshop was then hosted in the University of Limerick. It had 21 participants that were more so practitioners and healthcare providers, and those participants were from across the island of Ireland. I used reflexive thematic analysis to analyse the data. I'm not going to present all of the themes now as I don't have time, but I've picked out these 4 key areas to share quotations from, and then I'll move on to the implications. So, women experiencing homelessness have complex health and social care needs. When asked about their health, participants listed health conditions, and this first participant here listed hers, and then at the end there you can see she said probably have diabetes too. She hadn't had the chance to go to her GP to actually check that, but she'd been told that she maybe did and she should get it checked out. Mental health and trauma were described as being more important than the physical health needs. That was both by women experiencing homelessness and by staff as well. And the experience of trauma was really quite vast among the people I spoke to. Participants described physical and sexual abuse, trauma within hostels. For example, they'd watch friends struggle with addictions and in some cases die from accidental overdose. And one woman talked about being sexually abused within her hostel by a man staying in the same hostel as her. So another area to talk about today was the kind of interactions with staff that women experiencing homelessness had. Some experiences were positive, that's the two quotes on the right hand side of the screen, and then some experiences were more negative, and that's on the left hand side of the screen. The positive ones, women felt known by staff, they felt listened to, they felt like they weren't judged, they felt that staff had time for them. And then the more negative experiences really were where they felt stigma, they felt judged, and they felt that staff had preconceived ideas about them. So the next area is system design, and it was very broad, as you can probably imagine. Participants first of all described the issue with GPs, and if you didn't have access to GP, then the rest of access to secondary and tertiary care was more challenging, but the registration for GPs could be quite difficult in itself. Whether that was because of transience of women experiencing homelessness moving to new places, potentially not having ID they needed to register, or GPs having full patient lists and not being able to take on new patients. Then the need for viewing patients holistically rather than trying to solve problems separately was quite important. This participant on the right, her quote, she talks about all of the complex issues that women experiencing homelessness might face and how these need to be looked at holistically rather than individually. Other system issues included navigation of systems, rigidness of appointment systems, and then difficulty with the technical side of access. So that was around phone access and calling GPs in the morning for appointments. This participant at the bottom talked about peer mentors, which brings me on to my final point, involving people with lived experience of homelessness. So involving people with lived experience of homelessness was highlighted more so in the workshops than it had been in the interviews, but it had been mentioned in the interviews, which is why I included this finding here. This participant suggested that they need to be involved in the design of services, but in the workshops that was extended out to talk about including people with lived experience in design, commissioning, evaluating and delivery of services as well. So the implications from these findings are grouped under the acronym here, INVEST. The 5 concepts here act as principles really that should be considered and addressed when aiming to improve access to healthcare for women experiencing homelessness in Northern Ireland, but I would also suggest that these could be applicable to other populations in other settings as well. So involving people with lived experience is the key principle for improving access to healthcare for women experiencing homelessness in Northern Ireland. This involvement should take place on several levels. People with lived experience of homelessness should be involved in service planning, commissioning, delivery and evaluation. An effort should be made that it's not just tokenistic, but it's meaningful involvement. Examples could include involving people with lived experience at decision-making levels, perhaps at boards within charities, and as well as being involved in perhaps peer and buddy support at delivery level. Network refers to improving coordination and connectedness within health and social care services and also across health and hostel settings. Within healthcare systems, this could be done via models such as the Complex Lives model, which brings together multidisciplinary teams to discuss and resolve single cases from that holistic perspective. Connection across systems could also be improved using data sharing systems, such as the PASS system in the Republic of Ireland. That's a shared database that contains information on every homeless hostel bed space used, meaning that services can access notes and information about individuals so that the care can be connected and not unnecessarily replicated. Also included within this kind of network principle is the need for clearer defined pathways and handovers between institutions and the homeless sector. That can include discharge from hospital, release from prison, leaving the care system, and just really having defined pathways from those out. And then coordination issues also affect upstream in the more kind of government strategic level, where actually interdepartmental agendas and shared action plans could facilitate that holistic downstream working. Education for health staff include introducing the complexities and issues of homelessness and health into education at undergraduate and postgraduate level, as well as during continuing professional development. Education for both healthcare and hostel staff could include raising awareness about available services, and perhaps including some kind of online or physical service map that displays available services. Education should also be provided for administrative staff within GP services around issues of registration. And the aim would be that this education for both hostel and healthcare staff would help reduce stigma and the judgment that women experiencing homelessness may feel. Education could also include education and empowerment for women who are experiencing homelessness. So that can include that same access to that same online or physical service map, perhaps providing induction visits to health services when you first move to an area, and providing those peer or buddy